Good afternoon, or good morning, everyone. It's Hazel Rands and Dr. Elizabeth Coyne with you again. So again, we're offering the option to work through the second tutorial at your own pace. We know a lot of you were unable to attend, so we hope that this recording and some of our instructions will assist you in working through the third module, which relates to caring for both the well child and the child with an acute illness. So our learning objectives for this module and for this tutorial to assist you to understand paediatric assessment and how that varies in the non-acute and the acute setting. We're going to look in more detail about the immunisation schedule for children in Australia. Look at some of those specific care needs related to hospitalisation and some of that impact on family. And using the nursing process, which we've been using in our other workshops and tutorials, specifically looking at assessing families with young children. So we had another video available for you to use, and this one will be really helpful in just setting that scene and the context around what it means to be assessing a family with a young child. So we've got Vicky in the role of the nurse interviewing them, and then we also bring a social worker in. So again, that other resource isn't always a physical resource, it can be another health professional. So we didn't go through with the students in the tutorial and unpack that. That was your homework and another practice run before you start your written assignment task, which again is based on a video of a family assessment. So what we provided to the students, and I can barely read that, was an additional case study of a mum coming in with a young 8-week-old baby to your local community clinic where the nurses, their child health nurses or midwives will provide, 6-week-old baby, sorry, where they provide, they do an assessment, a developmental assessment, offer immunisation or advice about information, and then further advice related to infant nutrition and other elements of family and assessment and infant development. So,
and they also had she also had the little 3-year-old as well. So we sort of looked at sort of both children as well, which was quite good for the students to sort of understand both that small baby assessment, but then also looking at developmental stages.
So this is a family that has relocated and you're not familiar with, so it's their first visit at the clinic. Okay, so we've got little baby Alison, who was born at 38 weeks, normal delivery, no complications. She's fully breastfed on demand. You can see Alison interacting with her mother, so when her mum speaks, Alison turns towards her. And one of the things that we do at our child health clinics, or maybe at the GP at this stage, is that you would weigh the baby, check their length, check their head circumference, and we'll have a look at growth charts later. So these would have already been plotted on a growth chart when Alison was born in the hospital or the birthing centre. Okay, so then what we got the students to do was to break into groups or to work on the whiteboard, depending on the attendance, to look at some of these specific elements of infant assessment that are quite different to any other age and stage across the lifespan. So we look specifically at milestones. So if you have a look in the module, there's quite a lot of information there, and there's several short videos related to milestones. So immediately you would know that you've picked up that Alison is turning and listening and acknowledging that mum is there and starting to recognise mum, so that's a milestone. She's certainly not going to be walking or crawling or making any attempt at speech at this stage, but she might be, she'll certainly be responding to mum, might be starting to smile, probably has slightly better head control, so she doesn't have that head lag when you pick her up. And so a lot of these things we're not, we can observe that as we're having the conversation with mum, or they might be questions that we ask mum about what we'd be expecting a 6 to 8 week old baby that was born at full term, because we know that full term is anywhere from 37 weeks, the level of development that they would expect them to be at.
Often as you're handling the baby, weighing the baby, that's where you sort of might do that full body assessment as well. And you can pick up that they're grasping, turning, the way they're focusing. So there's a lot of that sort of information that you pick up as you go through. You might be doing a specific objective assessment, but then you're subjectively looking at sort of milestones, reflexes, and how this baby and the child is interacting.
So we then went on and talked about reflexes. So make sure you go through and read and understand what we call primitive reflexes are. So these are reflexes that the baby is born with, and they might relate to that sucking reflex, the grasping reflex, the startle reflex. And by 6 weeks, most of these will have started to disappear. And a lot of the milestones are dependent on those primitive reflexes disappearing and the child starting to move into that more older child, toddler stages. So those reflexes are normal in the newborn up to 6 to 8 weeks. Some of them will persist a little bit longer. If they persist longer than that, then there may be some concerns around developmental delay. We have got a growth chart that we'll look at and show everybody later. So these provide that range of expected growth across what we call percentiles for height, weight, length and head circumference. And we have different ones for males and females. And other countries, so in a lot of the Asian countries, they'll have percentiles that are slightly lower than ours, because generally children and adults are slightly smaller frame and a smaller build. We would be talking to mum about how Alison is feeding. So this is a baby that's fully breastfed at this stage. So it might be a good opportunity to ask about how she went with breastfeeding, or how she went with feeding Tom, the first child. And whether she's got any concerns about breastfeeding. And often, if they're with you for half an hour or more with a 6-week-old baby, there'll often be an opportunity to observe a feed. Or if she's identified that there's concerns with feeding, you might say, well, why don't you wait until she's due for a feed, and then I can come and see how that's going, just so that you can observe and watch, and there might be something that you can assist with, or everything might be fine.
Yeah. The next aspects that we talked about was the immunisation schedule, and it's important as a registered nurse to understand when these are due, and how to have those general discussions. And we go on with further slides to look at that in this tutorial, and just to sort of work through students' response of when the parents may have discussions and concerns. The infant-parent attachment, we actually it's often sort of looked at subjectively as you're watching that interaction, and we talked about sort of expectations, but also maybe the discussion if there have been concerns, and the mother might have voiced some concerns in relation to that. And the last one was just about child safety, and so this often becomes those discussions about child seats, cots, handling, and you can often see that that sort of the way that the parents actually working with the baby and the toddler, and if there sort of is a sense that there may be safety issues.
Yeah, and again, just remembering with all of these that there's very specific health policies around child health and maternal and child health within Australia. There's a whole lot of policies and documents available in relation to child safety, immunisation, and even some of that developmental information that again is readily available to the families that we're looking after. These are no longer just in the domain of health workers, which is really good. We are going to talk a little bit more in a little bit more detail in the final tutorial about child safety, with some of the specifics in relation to children in hospital and caring for children and mandatory reporting. So we will go on and talk about that later in that final tutorial. So one of the things that Judy starts to discuss with the nurse is some concerns about immunisation, and I think it's timely at the moment given the ever-present conversation about vaccination and vaccine hesitancy and reluctance, and it certainly is a conversation that is becoming very frequent with health workers. So we then ask the students to think about how they might respond to a mum who's been listening to other mothers about, suggesting that immunisation isn't necessary, that it's nonsense, that it's putting poison in their children. So we then went on with the student group and talked about how you might respond to that, thinking again about the responsibilities that we have as a registered nurse in providing information. And there's a link on the team site in relation to what ANMAC, our registering authority, recommend and include as part of our nursing competencies in relation to how we respond to providing information about immunisation. And it's always about following the science and following the health advice. Yeah.
And one of the things that we talked about was that it's important to actually talk to the family about the risk and what the diseases look like, to give them that information so they then are making an informed decision, not just about the vaccine and its risk factors, but the risk factors of actually if they had got the disease, and the risk factors and the number of sort of cases that are out now in society. We also talked about sort of that it is often in relation to childcare places and school that there is an expectation of being vaccinated. But it's really important that you do understand. So have a look at that schedule and think about sort of how you might sort of have those discussions. And the other thing to think about is making sure that the family actually understand the information. We talked in that first workshop about health literacy, and so it's important to sort of remember, making sure that you're tailoring your information. And so what sort of some ways that you may actually get to understand what the family's understanding, Hazel?
Well, ask them what they know. I think the other thing with this family is that they have a 3-year-old boy who's, they're looking at options for a different childcare arrangement for him. So he's obviously been in childcare before, so it sounds like he's probably been vaccinated before. So ask them what their concerns are. What have they heard? Where have they got, or where are they seeking their information? So again, directing them to recommended websites, directing them to where they can find information about the immunisation schedules, to those evidence-based sites rather than bloggers and non-verified Wikipedia, where the information is not evidence-based. So your responsibility as a registered nurse is to provide that information, but also making sure that the way you're delivering the information is as information, not as a directive.
Very non-judgmental and really validating their distress as well, and her her anxiety in relation to it, not just sort of saying, "Oh, don't be silly," but really validating that and making sure that it's information being provided, not direction.
Okay, great. And so then, as always, we would be looking at what some of those policies are, what are some of the elements related to some of these social issues that we might be able to direct our clients to. So, there's certainly the National Immunisation Schedule, there's a National Immunisation Handbook that's freely available online, even though it was originally intended for health professionals. There's a lot of policy, even if you look at things like the No Jab, No Play, which would influence decisions for the older boy if he hasn't continued his vaccinations. But, they're a new family in the area. She may have met some people that are providing other information that's concerning her. So always about redirecting back to that source of information that's reliable, rather than a bit contentious or not supported. Okay, so some of the things that we've, just to summarise, that we've talked about with Alison's family is immunisation. Could be quite isolated, having recently moved. She's got her other boys starting childcare, and she's obviously started some conversation thinking about returning to work in some capacity. So again, having those conversations with her, and again, letting her talk with, in that and you as the health professional being non-judgmental and letting her lead that conversation. And it might be that there are other resources or other health professionals that you could refer her on to, or some suggestions you could make in relation to childcare centres in the area, or play groups, or something where she might be able to build some connections. Okay, so I think we've pretty much covered all of those. So just that reminder that, you know, we're constantly referring you back to the nursing process, because this is what underpins our delivery of care regardless of what setting we're in. So we've done an assessment with this family. We've looked at what some of those concerns are and summarised those. We will probably then go to the stage of setting a goal with this family and doing some planning. So we look at family assessment. So we've got a genogram that we prepared earlier, even though we put the wrong name on for Alex. That's my fault. So Tom's the 3-year-old that's going off to childcare. So we did have a lot of other information about this family, but for the purposes of this, we're just looking at Judy and her husband and their 2 children. So again, type genogram as a type of family assessment. If we wanted to look at some of those additional connections, the strength of some of those connections, some of the weaker connections, so not having yet established childcare or some of those other support mechanisms that might support. We're not sure whether the grandparents live nearby or the connections that that Judy and her husband have with everybody else, so we could move this onto an eco map to provide some of that further information. We might also look at one of the family assessment tools that provides some more information. So we know that AFSNAG, so Australian Family Strengths Nursing Assessment Guide, looks at and assists and supports nurses to guide a conversation with a family to talk about the strengths within the family. And we can identify some of those. So if you go back and review this particular type of assessment tool, what we've identified here is the communication. So we know, well, Judy has identified that she does speak regularly to her parents and sisters, that the sisters do provide some support, and she used to go to a playgroup with Tom, so that might be something that she's interested in doing again.
Yeah, and it's really important to look at the module to sort of actually look at what other sort of family strengths were in that module and in relation to that family assessment, and that was actually in module 1, but then in these other modules we just keep going back to that family assessment.
Okay, so again, looking at subjective and objective, and before we were looking at a specific member of the family, we were looking at those subjective and objective data, so we would be doing the same when we're looking at the family more broadly to assess family function. So what are the roles within the family, what can we see, what does Judy state about the family, and what are we observing in relation to how she's interacting with the children, or the questions that she's asking, or the support she's identifying.
Yep.
So we can go through and do that with the family as well. So again, this is all still part of the family assessment, so that we can then make a plan once we've got all the information. So again, these were some of the things that Judy stated was happening. She's wanting to go back to work in a couple of months. She's wanting the older child to go to daycare, and she's got some concerns about that, and she's got some concerns about immunisation. And so objectively we can determine what type of family it is. We look at the structure of the family, who's in the family, some of those impacting factors in relation to having recently moved. They've got a bigger extended family, but we're not too sure just how much support they provide at this stage. Okay, so again, looking at assessment, and when we look at children, and we've gone through a lot of these in the earlier slides, so we're looking specifically at physical development and social development. So we can do a growth chart to plot their physical development, and social development, as we identified, one of the things that we're seeing is that she's already starting to identify and connect with mum by turning to her voice. And then we could talk again to Judy about what to expect, what's coming, what does she remember about what Tom did at this stage, is there anything that she's concerned about that might be different between the 2 children, or has she got any questions?
And these are all documented in the mother's child health book. And so these have the growth charts and the ability to actually have that information and really just sort of point out to the parents what to expect in the future. And has the immunisation schedule as well. Yeah.
So this is just a sample of the one of the weight for age charts, so a growth chart for a girl. and you can see the lines across there referred to as percentiles.
Yeah, and these are all in the module.
So then moving on to the other stages of the nursing process, so we're looking at planning care. So we would look at setting a goal with this family, and you might be able to formulate a goal that relates to immunisation for Alison. So you'd think about what sort of nursing interventions would allow you to support the family to achieve that goal, and then once you've implemented the care, how you then go about evaluating it. So remembering your SMART goal, thinking about at that stage where you're evaluating care, have you ticked off all those boxes in relation to it being a SMART goal within the time frame that you'd looked at.
And then we moved on to assessment of the child in an acute hospital situation. And we really looked at sort of the importance of actually having a look in the module and reviewing the mini lectures and understanding the depth of information. But we talked about some key aspects in relation to this, about that ability to assess a child. And one of the things was the importance of actually not going in and sort of touching the child until you've sort of done that observation, because once you start sort of poking small children when they're sick, then you tend to really influence their observations. And so we looked at sort of this paediatric assessment triangle.
Yeah,
just on the next slide.
Yeah, so on the next slide. So, and just before we move on to that, so you would have already covered primary survey and secondary survey in some of your other courses. So just remembering that again with young children, that primary survey, that A, B, C, D, E, very similar to adults, although in children with the E we look a lot more specifically at exposure, so their temperature, any skin rashes, what their skin feels like, are they well hydrated, and because we know that children can deteriorate quite readily from things other than acute respiratory concerns. So when we're looking at the paediatric triangle, it's different because we know that children generally deteriorate because their respiratory system is compromised. It's not as well developed as in the adult. There's some anatomical and physical differences that do make them not just tiny adults. So have a look at the section in the module that relates to some of those anatomical differences. But we refer in young children to this work of breathing, their circulation and their appearance. And it's quite different to if we were assessing it in an adult, because at this stage we're usually just observing and listening. So we're looking at, you know, how are they behaving? Are they consolable? What's their skin tone like? What's their, are they floppy? Are they listless? Are they responding when they're consoled? So how's that child presenting? Because a quiet, unresponsive, non-talkative child is a concern. We actually want them running around the room annoying everybody. That's a good sign of normal.
Yeah, yeah.
Work of breathing in children is also very, it's a cardinal sign around deterioration. So we'll see a lot more of those obvious physical signs in a child. Cyanosis is often a later sign, and you've got a child that's really deteriorating. But we will see things like that extra work of breathing. You can often hear those abnormal breath sounds across the room. You don't need to put a stethoscope on a child. They'll often position themselves, they'll hunch up, they'll sit up. Some of children that have got chronic respiratory or cardiac conditions, you'll often see them squatting because that's a way that they can expand their lung volume. And then you'll also see things like retractions. So you might see intercostal retractions, you'll see some tracheal tug. You'd rarely see that in an adult. Things like nasal flaring. So it's all about them trying to make that work of breathing easier for themselves, and so they get a lot of physical signs that they're struggling. We then go on and look at their colour. So we don't want to see a really pale child or a really ruddy, hot child. So they'll respond, and that physical appearance will be a lot more obvious. Things like mottling of their skin. Cyanosis is often a later sign. we don't want
Yeah,
them to get
very,
to that
very worried
stage.
by that stage.
Or their circulation might be compromised because they're bleeding, they've had some sort of trauma. So we're doing all of this without touching the child.
Yeah.
This is all observation, and it looks like a lot of information, but as a paediatric nurse you'll often pick these signals and these signs up as you're admitting a child through triage, and it's, you know, that one movement, yes, we're just going to go into another room and get you seen really quickly. We're not going to sit here and wait for an hour and a half.
Yeah, you're not going to try and sort of listen to the chest when you can hear them breathing and see that their effort of breathing. And it's important to remember that there is an actual paediatric observation form, which has got just slightly different aspects for highlighting. And one of them is that effort of breathing. As Hazel was saying, that it's a really key sign. And so it's important to have a look at this on the website, so you just sort of get an idea of how to sort of assess a small child, and then, you know, the sort of we go on in module 4 looking at adolescence.
So this will look at first glance very similar to your ADS chart. So that's your adult deterioration detection system. So acute. Children's early warning tool, and we have a range of these. I think there's 3 or 4 of those across the different age brackets, given that infants and very young babies are going to be quite different, and their normal range is going to be quite different. And also remembering that we rarely do a blood pressure in a small child. It's not really a sign that is an indicator for treatment. We're looking certainly at respiratory effort, oxygen saturations, and even pulse as an indicator for treatment in young children. So you'll rarely see a blood pressure taken in a children's emergency department.
Yeah, and it's really important when you're looking at sort of that peripheral sort of shutdown that babies and children often get, that sort of where you're taking your saturations from as well, and you'll often see them with ear probes or in different ways to actually measure that.
Yep. Okay. So then we're just going to, we finished off this session looking at hospitalisation and the impact on children and their families. So we know it can be extremely stressful and challenging, not just for the child, but for the rest of the family. And we know that the response that child within that family unit often depends on the developmental stage or the family functioning. So again, we're relating back to those family nursing theories that we talked about in Module 1. So thinking about and reflecting on, well, how does that impact on this family that's come into hospital? And we know that hospitalisation affects the child, but we also know that it often affects their siblings. They will often feel guilty, or they'll be jealous because the child who's unwell is getting more attention, or in the current environment, if a child's in hospital, then they have to nominate one parent who will then stay with them. So again, the siblings that are left at home and even the partner can often feel that they're missing out on being with the other family member, but they, you know, mum or dad are away from them as well. So there's a whole lot more information in the module about thinking about unpacking how hospitalisation impacts families.
Yeah. And I think, as we sort of talked about in the workshop as well, is that relationship to the family's developmental stage. So sort of what are the age of the other children as well, because that then changes the parent's priority.
Okay, and then finally, and I know we're going back to the assessment phase, but pain assessment in children is quite different and can be quite challenging. It can be very straightforward because children are generally fairly honest, but it's now, a lot of research now identifies it as being under-recognised, which means we're often under-treating. So we need to have different types of pain assessment tools to look at both the very young child, the verbal child, pre-verbal child, and the older child. So one of the ones that we use regularly is a FLAC chart. So that looks at face, legs, activity, cry, and consolability. So there's a chart for that on the course site. And we can use this for pre-verbal children or anybody with cognitive impairment. So we're looking at what their facial responses are, how they're moving their limbs, what sort of activity is happening, the type of cry, and whether they're consolable. So we're looking at all those visual objective signs rather than the child saying what their range of pain is. So then if we move on to a visual analogue scale, which we tend to use in adults, but we verbalise it. So we'll talk about, you know, how would you rate your pain on a scale of 1 to 10. So with a child who's verbal or who knows their numbers, you might be able to use a written number chart, or you might ask them to say where they think they are, and you would have to use some verbal description of that. Or you could go on, I'll just move this way so you can see our Wong-Baker faces chart, which again, you need to have a child that understands what you're telling them. So you tell them what each of the faces mean and ask them to say which one they think is them.
Yeah. And often there's a fair bit of education of both the child and the family that's involved in assessing using either the analogue or the faces, because you need to explain and you need to sort of really have the parents on board that they're not influencing the child, but the child understands what you're doing.
And I think that one of the other, you know, when we talk about it being under-recognised, which means it's under-treated, where in an adult we might look at, you know, regular 4-hourly pain relief. In a child, if they're sitting quietly on the bed, you know, flipping through a book or, you know, not misbehaving, then they must be comfortable. But often children will react by withdrawing, and so they don't want to talk about their pain because they don't really understand what it is. And they're already so overwhelmed by everything going on around them, they don't want to tell you something else because you might give them some medicine, and they definitely don't want any more medicine. So there's all sorts of reasons. And then other children are just really very honest, and there's no, you know, no issues about whether they require pain relief or not. So one of the things that has changed a lot probably in the last 10 years is the administration of regular analgesia for any children who've presented with a condition, whether it's a presenting condition or whether they've had surgery, is to administer regular pain relief. And it might just be paracetamol or ibuprofen, or it might be something much stronger. But just to keep that, just as we would with an adult in a surgical ward, giving that regular dose of a non-opioid analgesia to maintain them.
Yeah, and I think the other thing that we're sort of much more aware of is the pain in relation to procedures. And so there's a lot more sort of that sort of instigation of, you know, using anaesthetic cream prior to IVs, nasogastric insertions and things like that, to really be aware of the pain that those procedures cause to try and reduce the distress of the small child.
Okay, and I think that's a wrap for that module. So keep your questions going on the Teams site. We'll obviously be doing some more work with you around preparing for your end of trimester exams, which are going to examine this module. So thank you everybody, and I hope this was helpful.